Hi, I'm Adrena Austin with Trice Imaging, and with me today is Dr. Steve Rad, specialist expert in obstetrics and gynecology, MFM, and high-risk pregnancies. Thank you for joining us.
Thank you for having me.
Now, you are based out there in LA. Can you tell us a little bit about your practice?
So yes, I have a maternal and fetal medicine private practice here in Los Angeles called the Los Angeles Fetal and Maternal Care Center. And we have one main location with a few satellite offices, as well as other outreach that we do.
So we're hearing reports out from the US that in some areas, the lockdown is starting to be relaxed. What is the current lockdown situation out there in California?
Okay, great question. So starting in March until about last week, May 15th, we had very strict stay-at-home orders, and only very essential businesses were open, including hospitals and banks and pharmacies and grocery stores and physician offices. Since May 15th, the stay-at-home orders have been completed. However, now we're opening up in phases, starting with the most essential services first.
Wow. And how has the lockdown and those restrictions affected the way that you practice? Because it's affecting pretty much every facet of our lives these days.
Sure, like many physicians and maternal fetal medicine physicians in the country, we reduced our services to essential visits only, which in pregnancy accounts for a lot of the visits actually. And then many other visits were, as possible, changed to virtual or telemedicine.
So which examinations were you able to move over into a telemedicine scenario?
So a lot of our, first of all, consultations we had with patients in terms of, for example, their diabetes care, hypertension, some of the more chronic conditions that we were following, we were able to do those via telemedicine with the patient. Some of our genetics counseling, pre-pregnancy consultations, if patients had specific questions or concerns, instead of having them come to the office, those are all converted more to virtual or telemedicine consultations. In terms of ultrasound studies, a lot of practices we saw in maternal fetal medicine had the physicians either staying at home or certain parts of the medical center, and then having their sonographers do the ultrasounds in order to minimize exposure and, again, social distancing. And we also even saw that in an inpatient setting as well.
So how has Tricefy enabled you to shift over to more of a virtual care scenario?
Essentially, Trice acts as our electronic medical record. So I use it for, like I said, archiving all of our images get stored there as our PAC system. We upload all patient forms, including prescriptions, intake forms, financial forms, consents, referral forms, billing sheets, all get uploaded onto Trice. I also use it for documentation or a reporting system. I use it for what we call adaptive reporting, where we have various different reports based on the visits. I use it for writing prescriptions, for doing billing, like I mentioned before, but I use the reporting system. I've adapted it to what I need to do in my practice, so including the actual report for the visit, the consultation note, the telemedicine note, prescriptions, billing, and any other sort of documentation, freehand notes that I need to do.
You are also using the reporting functionality in Tricefy, but you're not just using it in the traditional sense. So Tricefy Adaptive Reporting allows you to make custom templates based on the needs of your practice. And you have taken that one step further by not only adapting it for traditional reporting, but you also use it to make different templates for billing and for coding. Can you share us some of those templates and show us how that works?
Yeah, absolutely. So when I log in, I can see the studies for the day that I have to review. And here you can see all the images that are part of that study. And here are the documents or attachments that are part of that study. Here's an example of a billing sheet that I do on Trice. So I have all these templates already created. So depending on what trimester I'm in, or what kind of study I'm doing, I have coding templates already in place. It auto-populates the date of the study for me, the referring doctor, etc. And then I can, I have all the ICD-10 codes already in place there, and then various different codes and whatever are applicable, just clicking around here as an example.
You have created all of these using our adaptive reporting templates.
Yeah, I made it myself. Here's an example of a prescription for blood glucose test strips and Lancets and a glucometer, insulin. So you can, here if I want to do like a consultation letter for a patient or a work note, I have it all. This is all very, by the way, you can see it's like within seconds. Please excuse, this patient's name is Radiance from work, due to pregnancy, whatever you want to write,
Right.
It's all, and then you finalize it, you can print it, you can then print it and give it to the patient, or you can send it to the patient or the doctor by text message or email, however you like.
So this really is a fantastic example of how flexible the adaptive reporting templates really are. How has adaptive reporting benefited you in your practice?
I like having everything in one place on Trice, and also because it's archived and stored and it can be accessed, anytime. I like to have everything in one place. So instead of using Trice as just my packs, I'm using it. I also made a billing template just so that I have everything in one place, and that's really been fantastic for me, because I also can go to wherever I am. Whether I'm in the hospital, I can pull up a billing sheet and do it right away. Whether I'm at another office or covering, I can, whether I'm doing a telemedicine from home or from the office or from the hospital, anywhere I am, I can instantaneously do everything in one place. I don't have to log in to an EMR, log into another system to do the billing, log into the billing website. You know what I mean? It's all in one place. So referral, and there's various different scenarios that can happen. An example is an OB does an ultrasound and they think that they detect like a spina bifida, for example, in a fetus. So before I can consult on that patient, if it's not an established patient, then and the OB wants to consult me, then they need to get forms signed and consent from the patient, and also get permission for billing, and we'll talk about how the codes for that work. So here's the example of, the OB was concerned about some signs of spina bifida. Here are images of the head and spine, for example, that they've sent to me. So I can upload them now onto this study that I made, and I can review the images that were done at the OB office. I can consult with the physician and explain to them what I see, what my concerns are, ask for him to refer the patient to our office for a more detailed scan. I can then create a consult note. I never face-to-face saw the patient, but I did consult, and I spend an hour on this, for example. Then that's called an interprofessional consultation, where I actually never saw the patient. So I'm part of the SMFM coding committee, and we have various coding documents that are have been created, especially during the pandemic, that will answer this question and teach you how to code. As part of the committee, we never, I always refer back to the coding committee. You can always ask us questions and all that on the website, and it's free. If you don't know how to code for something, it's free and anonymous, and we answer pretty rapidly. But here's a document, for example, that teaches you how to use interprofessional consultations that we as the coding committee wrote. And so in this case, this would be a consultation with the referring physician about this patient who I did not see face to face, and I would, depending on the amount of time I spent, I would use one of these codes. And actually, the referring physician, the primary physician, can also bill for the time that they took to consult with me using the code that's
Right.
here as well.
So there's various codes that the referring physician can use, and there's various codes that you can use as the performing.
Correct. So that's called an interprofessional consultation, and I would do the code, the diagnosis. In this case, was a spina bifida of the fetus. So that's a CNS abnormality. I put the gestational age, the referring doctor, and I would code for the interprofessional code, the time that I spent on this case. So those are the 99446 to 99451 codes, for example. So I would put the appropriate code here, and then I would be done with that's how I would do this example.
What are some other areas where you would be able to code? What if you saw an abnormality? So for example, a heart defect. I know you work very closely with a cardiologist. How would that work using Tricefy?
Let's say I look at this heart and I think there's something abnormal, although this is a nice example of normal, but let's say I thought this was abnormal, and I would send this to my pediatric cardiologist that I work closely with. On the cardiologist side, it's anonymized, and they don't have, and so it's safe and secure in that way. Okay, you can write notes. You can choose to share some of those notes as well with the cardiologist. And so in any case, here's the cardiologist. They're looking at the image, and they got that within seconds, and they can tell me like, okay, yeah, I think that there's something abnormal or not, or it's urgent, send her today, or it's not urgent, I can see her in a week or two, let's see how it evolves, or you don't even need to send her to me, bring her back in a couple weeks and see what it looks like. Or I agree that's a tetralogy abnormality, let's get her into the cardiac program and the perinatology program, and do multidisciplinary pregnancy planning. And so that one is likewise would be these interprofessional codes. The cardiologist can bill for using the consulting codes. I can bill for using the code as the referring physician that we talked about in another scenario.
So what would be kind of the required components of this consultation, this referral out, in order for yourself to bill for it and the referring physician? What exactly has to take place?
So it all depends on what the original setup you have, but it's described more in detail in the document. But anytime you're consulting with another physician or yourself, you just you want to make sure that the patient is aware that they've signed release forms and consents, they've agreed to whatever billing that's going to take place, and all those forms, the forms have to, you use the local forms, whatever consent forms you have in place, or whatever consent forms the consulting physician has in place. So that are all things you can easily set up between the patients, but within your office and between your subspecialist or primary referring doctors, you can have all that stuff already organized ahead of time. But this is going to be a patient part of your practice, so you need all the standard forms that you would normally have them completed as part of the chart before you agree to do the consultation. Everything needs to be documented. Then after, you need to generate a report and share that report with each other. So, and that's all described in detail in the document.
So let's talk about, when I think of telemedicine, I think of the patient portion, or the patient side of that. So I think of myself, if I were to participate as a patient, I would expect, you know, maybe the physician to call me. I've actually had my physician call me several times lately, which normally that would not happen here in the UK. But because of COVID and so on, and not going into the office and things like that, we're doing things over the phone. Tell me about that kind of virtual patient interaction.
Oh, so yeah, so that's probably what you're describing. One of the most common, like you said, you got some calls, right? One of the more common scenarios here in telemedicine is where you're doing, whether it's store and forward review of images or the live synchronous review of images and consultation. That's the, you know, traditional telemedicine or e-consult that everyone probably refers to. If you're doing telemedicine with the patient, you consult with your patient live, give them the results of the ultrasound, and if they're abnormal, you discuss the abnormal results, or then you start talking about whatever medical condition they have, like renal disease or diabetes or high blood pressure and pregnancy, and you do your consultation live synchronous. Then you can create your consult report on Trice and likewise bill for that. My apologies, I always refer back to the SM coding documents, but that's the purest way, because I'm part of the committee, and we recommend that you actually refer to the actual documents all the time when deciding on coding. But in any case, so here's the example that we actually have in the document, where a physician remotely reads and interprets a detailed anatomic survey, or we were talking to growth scan, for the indication of a suspected abnormality or fetal growth abnormality, and there's normal findings. Then the physician relays the normal results to the patient via telemedicine. We'll talk about that. And no additional consultation was performed. Then the physician will generate and complete a report for the study, and the recommended coding for that is a 76811 in this case, because the example is talking about a detailed anatomy scan for suspected abnormality, and they would add a modifier 26 to indicate just that they're only billing the professional component, and they're not going to be billing for any additional consultation, since they only relayed normal results. If they were going to relay abnormal results, do an additional consultation, then they would bill for what we call the E&M codes related to the service based on the time that they spent consulting with the patient. And then that is this additional document that we have that we were also already looking at earlier, about live synchronous. If you're doing live synchronous consultation with the patient regarding abnormal findings, then you can, as described in this document, bill for the consultation.
Thank you for sharing those various scenarios. I know a lot of people are having to adapt the way they practice, and this is very helpful for them to be able to see how it's done in a real world situation. Thank you for sharing.
Sure, thank you.
So the medical community has seen drastic change in the past couple months in the way that they have to practice medicine. What do you think will be the legacy, if you will, of these COVID times? Do you think that the adoption of telemedicine is something that will grow into the future? Or do you think when we return to hopefully a normal state or pre-COVID times, do you think there will be a reversion back to the way things were?
I think that's a great question, and probably on everyone's mind as we're rephasing back to normal or new normal. And I think that medicine will not be the same continuing going forward. I think everyone's seen the advantage of telemedicine, and I think they will continue to use telemedicine into the future, and I think it's going to be incorporated into every practice, as well as both outpatient and inpatient. And I think we will also be changing the way we train medical students and residents and fellows and physicians and other healthcare providers. I think that telemedicine is going to be a more accepted and more routine part of medicine going forward. And you can see there's a lot of practices that have already incorporated it, a lot of telehealth companies that are popping up. And I think that we've seen a lot of advantages of it, and it includes access to care anywhere, anytime, patients who normally wouldn't have access to this care, not just in an urban area, but in rural areas. Now that telemedicine is becoming a little bit more normal and more physicians are more used to it and adapting to it and learning how to use it, we now have seen an increase in access to telemedicine services in areas that don't normally have, for example, specialists or subspecialists.
It's interesting to see. You can almost see the history as it's written, but there are always those in the medical community who are trying to push for more virtual service and telemedicine and so on. And there is a lot of resistance. And of course, these COVID times have forced us to adopt.
Yes, absolutely.
And now you can see there are so many different positive implications for the technology. You know, it's finally here. It's a shame that this is how it got here, but I, like you, hope that it's here to stay, and I'm so proud that Tricefy will be a part of that virtual care revolution and that legacy. Dr. Rad, thank you so much. I know you're a very busy man, and I appreciate your time in speaking with us today and sharing your expertise with us.
Thank you very much. It was a pleasure, and I hope you found everything helpful, and I really enjoyed it.
Thank you.